Hi, everybody. I just had a heartbreaking turn of events. I just realized that I had paused my presentation. So I need to do it all over again. Oh, no, no tears for me. So today we're going to talk about social determinants of health. That's okay because I hadn't had enough coffee before I started it, and I was being challenged anyway. So, all right. So, which of the following are capable of bringing about a change in your health? Now, take a minute to look over these different categories and think about which are capable of bringing about a change in your health. All of them, right? All of them can influence your health in one way or another. The social determinants of health. It's it is comprised of a set of circumstances in which people are born, grow up, live, work, and age, and the systems put in place to deal with illness. These circumstances are in turn shaped by a wider set of forces, economic, social policies, and politics. And this is a definition by the World Health Organization. This slide illustrates the CDC health impact pyramid. You can see that uh, the smallest impact is at the top, lowest, or the smallest and the largest at the bottom. So socioeconomic factors have the greatest impact on health. Now, let's talk about religion and culture because religion has a huge impact on culture. And how does your religion and culture influence your health? Now, this is the definition of culture. It's defined as a set of beliefs, values, and assumptions about a life that are widely held amongst a group of people and are transmitted intergenerationally. So culture develops over time. It's resistant to change. Changing a culture is not an easy thing. Um, and each culture has its own unique organizational structure. Communication, family structure, child rearing practices, religious practices, and physical space. And culture is a big thing. Even the unit that you work on currently has its own culture. And I was a nursing director for 5 years before I switched and became a nurse practitioner. And I think one of the greatest challenges I found in my time there, I was also the educator there for 5 years, was trying to change the culture of the department. The nurses who had been there for a long period of time were more resistant to practice change, and I think that that's probably because those practices had been ingrained in them longer than the newer nurses. So if I wanted to implement a new process for doing something, it was met with great challenge. So one of the things I did to try to accommodate that is I would have the seasoned nurses, the ones who had been there for a longer period of time, actually work with me on the change, on implementing the change. And if they were part of the process, they were more geared towards its success as opposed to its failure. And there actually is a theory based on the process that I followed. The change. Oh my gosh, I can't think of it. It's a change theory. Mm. You'll learn about these things more as you move on in the program. But I actually followed that process before I even knew what it was. I learned what it was when I was getting my master's and doctorate degree. Um, so I think that sometimes it just comes natural to some people to know what to do to try to implement those changes. Culturally and linguistically appropriate services. So the CLAS has a set of 15 action steps intended to advance health equity, improve quality, and help eliminate healthcare disparities. And there's a blueprint for this. And if you would like to learn more about it, there is a link here that you can go to investigate CLAS standards a little more in depth. Here are some concepts of culture defined. Xenophobia, that's the fear of cultures, and um, the etic perspective and emic perspective, outsider, insider, and participant observation. So I can observe a culture from the inside of that culture or from the outside of that culture. Cultural competence defined, we have two different references here, and it's defined as the combination of culturally congruent behaviors, practice, attitudes, and policies that allow nurses to use interpersonal communication, relationship skills, and behavioral flexibility to work effectively in cross-cultural situations. Another definition is a set of attitudes and behaviors by nurses to take into account that the client or population's cultural beliefs, values, health practices, and ways of behaving in social interactions may differ widely from expectations of the health providers. The nurse uses cultural knowledge to accomplish the goals of care without violating the rights of the client or population. And I think that this is a really important slide. And many of you probably, you've been nurses a while. This is not new to you. Incorporate this into the care that you provide already. And this may be a learned behavior. It may be an innate behavior for you. But respecting others' cultures is of the paramount importance. We cannot force someone who has a different belief system to believe the way we think or to believe the way medicine wants them to be treated. We need to respect their beliefs on medical practices and oftentimes incorporate that into the health care that we provide. Some principles here. It's guided, cultural competence is guided by 4 basic principles designed for the specific patient or community. Care is based on the uniqueness of the patient's community culture and includes cultural norms and values. The care includes self-empowerment strategies to facilitate patient community decision-making and health behavior, and care is provided with sensitivity and is based on the cultural uniqueness of the patient community. Cultural humility. And this quote here says it all in a few words. To be culturally humble, it means that I am willing to learn. And I'm willing to understand and respect different points of view, actually. Stereotyping. So we have definitions. The first part of this presentation is really based on some definitions and hoping to help you gain a little greater understanding of some of the definitions. You probably know the definition of most of these. It's ascribing certain beliefs and behaviors without about a given racial and ethnic group without assessing for individual differences. It blocks the willingness of a person to be open and to learn about specific individuals or groups, and stereotypes can be either positive or negative. So not all stereotyping is a bad thing. We can insert positive stereotypes on a person that are not realistic as well as negative. Ethnocentrism. This is defined as the belief that one's own cultural group determines the standards by which another group's behavior is judged. So in a few words, saying that my culture is better than your culture and that you should conform to the way my culture believes. In contrast to cultural blindness, which there is an inability to recognize the differences between one's own culture, beliefs, values, and practices. So we need to recognize that there are beliefs, indeed beliefs between there are differences in beliefs amongst cultures, and we need to recognize that. Now, this is a personal reflection. I want you to think about this. So when interacting with a community consisting of cultures other than your own, do you provide culturally competent care with humility? Considering your own cultural and religious background, what are some cultural and religious practices or beliefs that influence your understanding of health and health practices? So I want you to think about that. You may have a patient whose belief system greatly differs from what yours is. Is the care you provide that patient influenced by that? It shouldn't be. And if it is, you need to work toward rectifying that. So we don't need to conform to our patients' belief systems, but we cannot allow their belief systems to interfere with the care that we provide to them. Now, what does race and ethnicity mean in relation to healthcare? Race is defined as a social classification that relies on physical markers like skin color, um, to the identity group as membership. And individuals may be of the same race, but of different cultures. So there are some people who have dark skin who are African Americans, and there are some people who have dark skin who are Mexican Americans or who are Indian, American Indian or Native. So, we cannot clump everyone in one character or one category because of their skin color. Race and health. Indicators of the socioeconomic status are not equivalent across race. Health is impacted by exposure to social and economic adversity over one's life, not only one's current socioeconomic status. And racism impacts health through stress and segregation. Now, this is what the census used in the last census, which was 2020, on defining someone's race. And I like the way that they have added subcategories here. It wasn't always like that. In fact, I was in women's health for 18 years before I switched to family practice. And when we were defining the race of our infants who were born on the unit, they were white, they were black, they were American Indian or Alaskan Native, or they were Asian. That was it. There were 4 different categories. And I like the way that the U.S. Census has taken that Asian group and put it into all these different subcategories because they may not have the same health disparities amongst the groups, right? So when you're lumping all of the Asians into one group, that is really unfair, or you're getting skewed data. And I also, again, like the way that the Hispanic, Latino, or Spanish origin have been segmented into other subcategories. Because, again, the health discrepancies, the cultural belief systems may differ greatly amongst someone who is Mexican and someone who is Puerto Rican or Cuban. Now, what is ethnicity? Ethnicity is defined as the shared feelings of peoplehood amongst a group of individuals. It reflects membership in a cultural group, and it's based on individuals sharing similar cultural patterns. It represents the identifying characteristics of a culture, like race, religion, national origin. It affects beliefs, behaviors, and access to resources. So members of an ethnic group are likely to give up aspects of their identity in society when they adopt characteristics of another group's identity. However, when there's a strong ethnic identity, the individual maintains the values, beliefs, behaviors, practices, and ways of thinking of their group. So, for example, we have the example of those immigrating to the United States. They may adopt some of the characteristics of someone who was born and raised in the United States. However, they more typically will maintain their values, beliefs, behaviors and practices. Prejudice and racism. Prejudice is the emotional manifestation of deeply held beliefs about a group. This is usually considered negative, and racism is a form of prejudice that occurs through the exercise of power by individuals and institutions against people who are judged to be inferior. So racism limits opportunities for certain individuals, and that is based on prejudice. Hot versus cold cultures. Just take a second to look at this slide. It goes into a little more depth or understanding in the next slide. So let's look at this one. Consider your own racial, ethnic group and how it experiences privilege and or disparities. And you can go and take a peek at these short films if you like. I know that you're really pressed for time in your life between work and school, but if you have some spare time and you want to take a listen to these short films while you're driving around, that would be a good thing. Now, how does race influence health? Some questions I want to pose to you. And how would you define your racial category according to the 2020 U.S. Census categories? How well does that reflect your identity? And what does it mean to be your race in the United States? And how does whiteness influence health if it does? This slide talks about inequity, inequality, and disparities in healthcare, and how they all interrelate with each other. Inequality versus inequity. What is the difference? Health inequality is the difference in health between groups of people or countries, and health inequity is a group difference in health outcomes that is systemic, avoidable and unjust. And this is our former U.S. Surgeon General, and he has a YouTube video that goes into more depth on health equity. If you would like to take your time to view this, this is here for you to go into a little more detail. I think this slide says it all, right? We've got equality here and equity. So equality, everybody's invited to the game, or everybody can go to the game, but not everyone can see it. Equity, everybody can come to the game and everybody can see it as well. So some cases, I think a picture can say 1,000 words. I think these two pictures sum up equality and equity perfectly. Now, health disparity and inequity, what is it? It is a type of health difference that is closely linked with social, economic, and or environmental disadvantage. Health disparities adversely affect groups of people who have systematically experienced greater obstacles to health based on their racial or ethnic group, religion, socioeconomic status, gender, age, mental health, cognition, sensory or physical disability, sexual orientation or gender identity, geographic location or other characteristics historically linked to discrimination or exclusion. And this comes from Healthy People 2020. And this has a huge lump, right? There are a lot of people or groups that suffer from disparity or inequity in healthcare. And so when we look at social determinants of health, we are trying to identify and rectify the causation of these inequities and rectify the situation so that these populations can have access to health care and thus reduce their long-term risk of developing these health issues. Areas of disparity. race or ethnicity, socioeconomic status, including education and income, gender, sexual orientation, geographic location, neighborhoods, urban versus rural, inner city versus suburbs. And I think that there are definitely, I mean, you have to see the big picture on all of these things, right? So geographic location, neighborhoods, urban versus rural, inner city versus suburbs, they all have their areas of disparity. And here are some examples of health disparities in the U.S. The infant mortality rate for non-Hispanic Black women is 2.4 times the rate of non-Hispanic white women. Asthma rates among Puerto Rican Americans are almost 3 times as high as those of the overall Hispanic population. Asian American women were the least likely to have had a Pap test compared with other women. And rural counties are more likely to report fair to poor health than urban counties. Interesting. Rural counties also have more obesity than urban counties. Now let's look at these graphs. We've got a few graphs coming up here. The life expectancy at birth by years of education at age 25 for white females. Now this is an old statistic from 2008, but unfortunately it takes so many years to gather this data. By the time it has been published, it's outdated. But this can give you an idea of the years of education and life expectancy. So the greater the education, the higher the life expectancy. Interesting. And life expectancy at birth by years of education at 25, and this one is defined by race and sex. So you can see here years of education down here at the bottom. If you have 16 or more years of education, look at how your life expectancy increases. And here we have Hispanic females having the largest life expectancy, followed by white females, then Hispanic males. White males and black females are pretty close, and then black males have the lowest life expectancy. And when you look at years of education, those who have a less than high school education, you can definitely see a huge drop in life expectancy, overall life expectancy. The Hispanic paradox, on the average, they have a lower income, yet higher life expectancy and lower mortality than other conditions. Possible explanations for this can be lower rates of smoking, healthy immigrant effect, and strong familial and social networks. And there's an article that's going to be coming up that you can read if you should desire to learn more information on that. And this slide illustrates in greater detail the Hispanic paradox and life expectancy. So even though historically they earn less money and are in a lower socioeconomic condition, they have a higher life expectancy. And this one, AHRQ, this is a great organization. You can get a lot of wonderful statistics from this. This is something that this is a site that you might want to save in your favorites. The rates of hospitalization for ambulatory care sensitive conditions were 32 to 87% higher amongst patients from the poorest communities. Wow, this is really stark, right? From the poorest communities. So the dark blue indicates poor, and then the lighter blue indicates not poor. And poor was defined as an income of less than $38,000. This was done by zip code. That's one of the things I like about AHRQ. If you can get some really finite or defined statistics by zip code. But this one, look at this one, wow. With CHF, congestive heart failure, pneumonia, huge. And then we look at the relationship between housing, education, and strong employment affecting the chronic condition of asthma. All of these things increase the risk of asthma. Increased poverty causes poor housing, increase in asthma, more school absenteeism, less education opportunity, less employment opportunity, less social capital, less resiliency, increased poverty. It's a cycle. It's that cycle. Now, moving forward, we're going to talk about what's being done to help address these inequities in healthcare, right? And health disparities. So social, political, and economic factors need to be addressed to improve the health of those affected by these disparities. And the WHO came up with this conceptual framework in the socioeconomic and political context. So governance, macroeconomic policies, social policies, public policies, culture and societal values. And you can see that these interact with socioeconomic position, social class, and gender ethnicity. And these these interact with material circumstances, behaviors and biological factors, psychosocial factors. They all have an impact on equity and health and well-being. So in these first two categories, these are the structural determinants, social determinants of health inequities. And these are intermediary determinants of social determinants of health. They all ultimately have an impact on equity in health and well-being. Whoop, this one didn't turn out so well. So Healthy People 2030 is coming up, and they are working on it diligently now. Every 10 years, a new initiative is addressed, and in Healthy People 2030, their main their main focus is going to be on the social determinant goals and addressing these disparities. So, the U.S. Surgeon General report strategies to reduce these disparities to ensure a strategic focus on communities that are at the greatest risk. And that's one of the reasons that if you look at your medical record and your electronic medical record now, it's asking for all of this information related to have you worried about housing? And these questions are maybe asked regularly, but they definitely should be asked on that annual health and wellness check. That's how we're going to get this data to reduce disparities in access to quality health care. And this is getting harder and harder because more and more health care is being placed in these huge conglomerates like Advocate and Ascension and Endeavor. They're becoming money-making machines. Gone are the days of these community hospitals that really had the patient's best interest at heart. Now we have these huge money-making machines here. And increase the capacity of the prevention workforce to identify and address these disparities, support research to identify effective strategies to eliminate health disparities, and standardize and collect data to better identify and address these disparities. So data, I'm very data-driven, so data is so important. We need to find a common language to talk about these social determinants of health. And in research, when you're doing research, testing over and over again is so important, right? And we need to talk about how we can rephrase things in a common language that people can understand. Priming audiences about the connection with messages that they already believe makes that concept more credible. I'm a big believer in scripting too. Use one strong and compelling fact, a surprising point that arouses interest, attention, and emotion. Identify the problem but offer solutions. Incorporate the role of personal responsibility. Mix traditionally conservative values with traditionally progressive values, and focus broadly on how social determinants affect all Americans. All right. So health starts long before an illness in our homes, schools, and jobs. So all Americans should have the opportunity to make the choices that allow them to live a long, healthy life regardless of what their income is, their education level, or their ethnic background. And the neighborhood that you live in shouldn't be hazardous to your health. Your opportunity for health starts way before you need that medical care. It begins where you live, learn, work, and play. And the opportunity for health begins with families, neighborhoods, schools, and jobs. And there is a link here that will give you some more detailed information on framing the message of the social determinants of health. Some additional resources to help you identify interventions related to these specific health concepts. The Community Preventative Services Task Force, and here's a website you can go to put that in your toolkit. Community Health Navigator, and you may need some of these sites to gain some information for your assignments, so I would strongly encourage you to keep track of these sites. And here's some more resources for you as well. CDC, World Health Organization, and AHRQ, all of those are, I use CDC all the time. Unnatural causes, and this is a video that you can view. It speaks to the question, is inequality making us sick? There's a TED Talk here on health disparities by Dr. Lisa Cooper. It's on YouTube. You may take a moment to take a look at this one. Or Dr. Den Berwick. You know what I like about this, and one of the reasons that I'm recording all of these PowerPoint presentations is I know how busy you are. I know what your schedule is like because I've been there, done that. And if you can listen to these while you're driving the car, or when you're cooking dinner, or when you've got some downtime at work, this is going to save you a lot of time as opposed to having to read all of this stuff, right? So I think that accessing these and downloading them and listening to them when you can, or if a minute arises, is a good thing. Racial and ethnic approaches to community health. Another website for you. And oh gosh, I wish this hadn't happened. I was trying to make the presentation look better and I ended up not doing so. But here are some websites on strategies and approaches to improve mental health. And there are 3 web articles here that might be helpful to you. The mental health system in the United States is embarrassing as far as I'm concerned. I think the greatest thing that has come out of it is the development of the psychiatric nurse practitioner. And these programs are just booming everywhere. And I'm hoping that when we get more advanced practice nurses in the field of psychiatric nursing, that we're actually going to have an impact on the promotion of change where mental health is concerned. I hope that you found this presentation helpful, and I do apologize for some of these mess ups on the slides. Again, I was trying to make the presentation beautiful, and unfortunately I skewed some of the articles on the slides, so I do apologize for that, but I hope that you found this helpful.